Okay, so our next session, Bridget Blaney, who is the nurse manager for the Spinal Cord Injury Rehabilitation Program, Inpatient Rehabilitation Program, and possibly other nurses from the program. I don't know, she'll have to let us know, but she's with us today. She's been with us all day, part of the planning committee as well. So Bridget is here to talk with us about secondary complications after spinal cord injury and hopefully some ways to prevent them. So Bridget, thank you for joining all day and for planning this. Welcome, take it away.
Megan, it is not letting me share my screen.
I need to stop sharing first.
Okay.
So now you should be able to.
I just want to apologize because I'm not the best at this.
It's coming up. There you go.
Can everybody see my screen?
Yep, looks good.
All right. So I do apologize. I do not have any of my wonderful nurses here with me to present, as I'm sure you can all imagine. Staffing shortages are pretty much everywhere, so it's hard, and our census is high back at work. So, and I'm actually currently on leave, so I will be doing this alone from the comfort of my home. So yes, my name is Bridget Blaney. I am the nurse manager of the Spinal Cord Acute Rehabilitation Unit over at Metro Health at the Old Brooklyn campus. I have been in spinal cord injury pretty much my entire duration at Metro. I started in '98, so I'm coming up on 23 years. I did leave 1 year, so 22 out of those 23 years has been spent in SCI. I did just take over the nurse manager role from Nilda Mercado back in 2019. So hold on one second. So I'm here to talk about some medical complications in individuals with SCI. So on the inpatient unit, we generally are working with patients in the acute phase of their injury. So the complications that we see acutely are not necessarily the same, you know, the patients with SCI, and I'm sorry, I use the term patients, persons with SCI have long-term. So generally in the acute phases, you know, we're dealing with orthostatic hypotension, we're dealing with PEs. At this point, we're trying to, what I feel like is cramming a lot of information for our patients in a very short amount of time, sometimes only, you know, 4 weeks for some of our patients. And a lot of times I'm not sure that they hear anything that we're saying just because they're trying to cope with their injury, and then, you know, giving them all this information is just very overwhelming. But I'm focusing this on generally medical complications that patients with chronic SCI, and chronic is defined as any person living with an SCI greater than 1 year. So individuals who sustain both traumatic and non-traumatic SCI are living longer due to advances in medical care research and living more active lives. This can come with some unexpected complications even years after their initial injury. And these impairments, you know, are affecting various aspects of their lives. So the first medical complication I want to mention is syringomyelia. It's actually on the rarer side. It only affects 3% of persons with SCI. And what this is, it's a fluid-filled cyst. You might hear the physician use the term syrinx that forms within the spinal cord. Sometimes it will just increase over time. So, you know, you may not realize when it initially developed. And it can cause some spinal cord compression, progressive muscle weakness, and, you know, which will lead to some loss of function. And this can occur years after injury. I'm not sure, and I don't know, Megan, if you can tell me if there's any physicians on our link right now, just because what I want to mention here a lot is being an advocate for yourself. I think sometimes, I don't want physicians to get mad at me for saying this, but I think sometimes we need to really, you know, press physicians to look into something that we know is not normal for us. So generally they'll, diagnose something, they'll diagnose this with a CT scan or an MRI. And treatment can be something as mild as just some ongoing monitoring, just to, see if maybe it, won't grow over time. But at some point, if it does get to be too large and too invasive and, affecting your function, you may need to have surgery to remove that fluid-filled cyst. Another one is neuropathic joint disease. This is generally a more delayed complication in patients with SCI greater than 15 years. This is the slow destruction of joints, such as your hips, your knees, your ankles, your shoulders, elbows, and spine. This can present as a deformity, like an obvious deformity, pain below the sensory level of injury. Again, the more impaired, like loss of function, neurologic function, sometimes you'll hear an audible clicking. That's usually in the elbows, shoulders, and knees, and your hips. And then treatment can, usually they'll diagnose this with an X-ray. Treatment can include something like monitoring, medications, bracing. They might order you some physical therapy. And if needed, it will also include surgery. So some of this, I feel like it sounds like arthritis. But again, I feel like if you are a person with an SCI and you were injured, in your early 20s, doctors, wouldn't want to, maybe get x-rays or, suspect, arthritis in somebody, who's 35. So this is just where, you might have to like push, for the physician to, do that x-ray if you know that something's different. Spasticity. So yes, this is a big one. It affects 65 to 78% of persons with SCI. I did think it was interesting just hearing from Dr. Hensel in one of our prior talks, about how spasms can be good, they can be bad. I know in the acute phases, for nurses, it's sometimes frustrating because, we know patients are having spasms and, we feel like if they're waking them, they're waking patients from their sleep, they're inhibiting some of their ADLs and things like that. And sometimes our physicians are reluctant to treat spasticity. Generally, I think that they do that initially just because they know that they're gonna, we want these medications to work for the long term. And we usually use things like baclofen, Xanaflex. In rare cases, I've seen them use Valium. I tell you what I have been seeing a lot is these intrathecal drug pumps. Usually it's baclofen. I would say like 10 years ago, we would see maybe one a year. Now I would say we probably see 5 or 6 a year. So I do think that those are being used more, and Botox injections. We are doing those actually inpatient. I know before we weren't allowed to use them inpatient, and within the last couple of years, they've now been doing the Botox inpatient. Cardiovascular. So again, in the acute phases, our patients, I would say almost always have a hard time regulating their blood pressure. So that's why we're using the TED hose, we're using the binders, and we try to have the patients not require those when they go home. However, sometimes we're still using that. This generally is affecting patients, with thoracic and cervical levels of injury. And again, it affects 60% of patients, and will develop this orthostatic hypotension. Now, why I think this is important to mention is, because this is generally, chronic. And so maybe prior to your injury, your blood pressure was, 120/80. But, since your injury, patients will generally tend to run on the lower side. So their new normal is, 90/60. So it's very important to know what your normal blood pressure is, um, for a couple of reasons. One, because you should know it, but two, just because, and one of the other complications of AD is, I think sometimes I have, heard patients, um, when they come back, to visit or, to talk, they'll say how, they went to the doctor and, their doctor wasn't concerned about their, 140/90 blood pressure when, that was a significant change for them. But back to the orthostatic hypotension that um, our patients with chronic SCI have, we usually will treat that with medication. We usually, I know on the inpatient side, we use midodrine a lot. And then you can also use things like the compression stockings, also known as like the TED hose, those white stockings, and abdominal binders we use a lot. Oh, autonomic dysreflexia. This is a topic I feel like I could probably talk an hour on. This is a condition that usually affects patients with T6 and above SCI. This is a serious spike in blood pressure for that patient. I will tell you, at work, we have these new cards that we give to people, and we ask them, we'll actually give them like 4 or 5 of them, just so, the patient has one, their caregiver has one, significant others have one, daughters, children, whoever, is around the patient, just because we try to make sure we educate that, this is a serious medical emergency for the patient. And sometimes you can manage it at home. I know, I feel like I've been a nurse forever. Back in the day, we used to prescribe nitro paste, for patients when they were discharged. And, we don't do that anymore. So, we want you to go to the emergency room. And what we were finding is emergency rooms have no idea what AD is. So sometimes, giving the patient that card, to give to the emergency room physician has been, extremely helpful. We've actually had some ERs, like from Ashtabula and, out in some more rural areas, call and like thank us, just because, they did not know what AD was. They didn't know how to treat it. So we do have those cards. I do have my contact information at the end of this presentation, so I'm happy to mail them out to anybody who wants them, just so that they have them. But again, back to, knowing what your normal blood pressure is, and I hope everyone here, has a blood pressure cuff and is monitoring their blood pressure at home at least, once a week. Just so, you know what you are normally running. We generally recommend checking it in the morning, right after you wake up. But again, if you're normally 90/60 and, you're all of a sudden like 130/90, there's something going on. And some of our patients, we know some people, have the classic headache. They'll have the chills, the rash, the low heart rate, things like that. But, sometimes patients have been completely asymptomatic, especially if it's something chronic that has been going on. For example, like a renal stone. So let's say you have a kidney stone and, your body knows you have it, it's, again, you're getting, the higher blood pressure. But, maybe you don't, feel the pain that you would normally, be feeling with that kidney stone. So generally, causes of AD are, we always tell patients it's either bowel, bladder, or skin. And so those are some of like the first things that, I'm sure, everyone knows to check, is your bladder empty? Is your bowel empty? Are there any skin issues? Tight jeans, I have to tell you, I remember one time having a patient, we couldn't figure it out. And then after, some time it was, their, tight clothing. And again, I think it was Dr. Hensel that, touched on, when a woman is, pregnant, she can have complications with AD, throughout her pregnancy. And then just other things where, normally, if you have an appendicitis or a gallbladder attack, you would feel that pain, but if you're not able, to feel the pain, it'll present with that higher blood pressure. Other things are some medications like nasal decongestants like Sudafed, other things like that have been known to cause AD. respiratory. So again, one thing, it's respiratory issues are the leading cause of death in patients with chronic SCI. So we try to focus very hard on patients, maintaining a good respiratory status. Again, this is more crucial for patients with cervical level of injury and thoracic. They are the ones that are most impacted. You also have more of a risk for things like sleep apnea, weaker chest and abdominal muscles. So sleep apnea, I will tell you, affects more people than you would think. And it's kind of hard to diagnose because it would probably be hard. You have to usually Metro, their facility, we used to have some beds in the hospital, but now I think they have you going to a hotel. So now you go to this hotel and you sleep there for the night, which can sometimes be difficult to get a formal sleep study for patients with SCI. But again, you're more at risk for developing sleep apnea. Also things like pneumonia, bronchitis, atelectasis, again, pulmonary embolism and respiratory failure. I'm sorry, I put sleep apnea on there twice. And we want to prevent these complications. And I don't want to, be a big, oh, get your, flu shot, get your pneumonia shot, and COVID shot. But, doing these preventative things is, just such a great tool to, prevent these respiratory complications, and like I said, this is the leading cause of death in persons with chronic SCI. So I can't, emphasize it enough on how important it is, to be aware, and not be afraid to, like if you've had this cough or, I mean, because sometimes maybe it might be something as easy as, the doctors can order an inhaler for you, or a nebulizer or aerosols. Maybe it's something we can, teach, a loved one, the cough assistance, if you're not able to exert like an effective cough, different positioning, different things that, we can, do to help you just, keep you out of the hospital and, keep your respiratory function functioning well. Heterotrophic ossification. So in the medical world, we kind of abbreviate this as HO. So this is abnormal bone formation in the connective tissues and muscles around joints. Again, the hips, the knees, the elbows, shoulders. And this affects a lot of persons with SCI. In fact, when you look it up, immobility is one of the leading causes of this. And it is painful, and it does limit range of motion, and it does impact like if you have a lot of this heterotrophic ossification in, like, let's say your hip, I have seen, let me just rephrase that, where we will actually like turn the patient and it ends up fracturing their hip or something like that. Again, it presents as pain, but again, if you're not, feeling that pain, it might be, a raise in blood pressure. Fever, increased spasms is another indicator that you might have this HO, and it's usually diagnosed by an X-ray. Sometimes, by the time the deformity is seen, I feel like it's probably, too advanced, and you're definitely looking at a treatment such as medication. Sometimes if you catch it early enough, range of motion and things like that, and therapy, might be helpful, and you could, alleviate having, another medication added. But I will tell you, we do see this a lot in our world, even acutely. But it definitely is something that as you are, getting older with your spinal cord injury, can see as well. Infection. So, with the spinal cord injury, you have that secondary immunodeficiency. It disrupts your white blood cells, and it makes you more prone to infections, any infection. The UTIs, pneumonia, other types of respiratory infection, wound infections. This is where I really, when we're talking to our patients, we want them to have a very good relationship with their PM&R physician and their primary care physician. Just because, you know, you want to have that type of relationship where your doctor knows you and you know your doctor. And so if you keep that up and keep up with your appointments, you know, you can maybe, you know, call in or send them a My Chart message and just say, hey, you know, I really think I might have a UTI, you know, and, you know, they would be happy, you know, to give you something maybe even over the phone, or just call in a prescription to your pharmacy. But if you don't keep up with your, you know, preventative care with your physicians, you know, they're not inclined to do that. And they want you to come in. And again, like Dr. Olson mentioned earlier, if you're not better 24 hours after taking that antibiotic, you need to make sure, you know, that you call and you say, hey, you know what, you know, I've been on this antibiotic for, you know, over a day and it's, you know, I'm not feeling any better. You know, I still have considerable symptoms. Other medical concerns, you know, obviously, you know, like the bladder dysfunction, you know, things like the UTI, kidney stones. So renal stones, I would, you know, usually we encourage patients to get screened fairly routinely, just like any other like routine, like, you know, mammograms, colonoscopies. But if you have a spinal cord injury, you should be having routine ultrasounds of your kidneys, just to rule out things like stones. Because again, you might not know that you have them, and you know, the doctors want to keep an eye on them. Again, you know, sometimes when we've had patients that, you know, where we couldn't find why they were experiencing AD, you know, kidney stones has been, you know, one of those things. Bowel dysfunction. This is another topic that, again, I think last year's forum, we actually ended up, you know, talking quite a lot about it. Again, I feel like we probably could make a presentation on it. And I feel bad because on the inpatient setting, we're, you know, doing bowel routine at night, and most people do it in the morning. But, you know, sometimes, you know, any little thing can set off your, you know, your bowel habits with SCI. Pressure sores, make sure to check that skin. We encourage you to do it daily. Patients with darker complexion, you know, in the hospital setting, I know we get, you know, frustrated because, you know, by the time we've noticed that discoloration in the skin, a lot of times there's been, you know, too much, you know, damage, you know, and so we always, you know, tell patients, you know, it's going to get worse before it gets better. So just kind of making sure that you check your skin for different types, any sores. And again, Dr. Hensel's presentation, you know, I didn't think of educating our patients about, you know, especially, you know, after any, you know, type of sexual activity to be checking their skin. Neuropathic pain. This is something we actually talk to new nurses about every single time, that it's, you know, just, I can't tell you, I would say that every new nurse we get in our facility is blown away by the fact that patients with spinal cord injury feel pain. It's such a misconception, and it's unfortunately a lifelong complication for some spinal cord injury patients. And generally, you're working with your physician, your PM&R physician, your primary care physician, on ways to combat that. Again, preventative care is you know, what I consider to be the best line of defense for our patients with spinal cord injury. Prevention, early diagnosis, treatment of any symptom or infection is critical to improve any, you know, like complications, to improve survival, improve community participation, and maintain a quality of life. But other than that, I don't know if anybody has any questions.
I need to unmute first. Yes, we do. Dina has a question. Go ahead, Dina.
Yeah, so you were talking about intrathecal pain pumps?
I'm sorry, they're not pain pumps, they're for spasms, which I know spasms can, you know, cause pain. And that's generally the intrathecal baclofen.
Yeah, that's what I was talking about. So that's for spasms?
Yes.
Okay, because I have an interthecal pain pump from Medtronics. That's different?
It might be different. If you wanted, I mean, I don't know how much you want to share. I mean, you don't have to share, what the medication is, but
Well, I have it for a pain pump. It's from Medtronics. They put in an interthecal pain pump, and it does not have baclofen. It has bupivacaine and fentanyl. Is that something else?
that is for pain.
Yeah, so that's different than the baclofen?
Yes, yes.
Okay, so the spinal cord stimulator I have, that would also be different?
The
I have both machines, because the spinal cord stimulator stopped working. I mean, it stopped being effective after 6 months. So about half a year later, they put in or a year later, they put in the spinal cord stimulator. They put in the pain pump.
I'm not too familiar with the pain pumps. We don't see a lot of, but again, I feel like our doctors are probably more hesitant to do it on patients that have that initial injury. But from a chronic standpoint, again, when I was researching for this presentation, again, I feel like nerve pain is another thing that we could. There was all these different types of nerve pain, and that's that I feel like is a presentation in and of itself.
I have peripheral neuropathy that's just constant, and pain that's just constant due to broken back. But you wouldn't know when you see me, because there are some days I could walk, but the pain is chronic.
I'm very sorry.
Yeah, no, it's okay. I was just wondering if you knew anything about that, because everyone tells me that baclofen, but I'm just wondering if baclofen is also used in a pain pump, or if it's totally different things.
Yeah, I think the type of pump you have is probably more for the pain. And again, that's probably something you and your primary care doctor or PM&R doctor discussed. And I mean, I think they also use pumps for other things like insulin. I know some people will have like an insulin pump, and but yeah.
Excuse, I was just going to ask if anybody else had questions. So if you were going to say something, Bridget, go for it.
No, if anybody has any questions, I did put my information in there. And again, I really encourage, anybody, if they, had anything they wanted to share, I hate to put a plug in for, our patients that are inpatient, but, we're looking for, patients all the time to, talk to like our current patients that are going through it. And I know, Megan does it a lot. But, just, we're always looking for people, to kind of, because our patients can hear us, all day long, but, unless they, see somebody out in the community, I think that's very helpful for them.
So I will insert a shameless plug into the United Spinal Association Northeast Ohio chapter's peer mentoring program. Connect In is what we call it. And we do have peer mentors that go to the inpatient rehab floor to speak with new injuries. If you are interested in doing that, send me an email, get a hold of me somehow, send me an email. And I can explain in more detail about the process of onboarding and things like that. But if you're interested in being a peer mentor for newly injured patients, let me know. And at the same time, if you would like to be linked with a peer mentor, we do have mentors that speak to anybody post-injury, no matter how long they've been living with a spinal cord injury. So either way, if you want to be a mentor, or if you are interested in speaking with a mentor, reach out to me and we can discuss more of those details later. But if anybody has any other questions, I did have a question if I can remember it. But if anybody else has something to ask, please do.
or even something to share, you know, in terms of, you know, their personal, you know, experience. Yeah. I would love to hear about it.
Yeah, my question isn't coming to me.
Yeah. I probably talked too fast, Megan.
So we do have about 10 minutes or so. If there is no other questions, we can't, I do see our next sponsor presenter on. So if we want to just keep it moving, we can do that. So I will, let me stop recording this one first. But before I do, Bridget, thank you for that presentation. I don't want to skip over that. It was very well thought, very well researched, put together, very informative. So thank you very much.
My pleasure. I'm sorry, I'm not the best at public speaking.
You were
Thank you.
great. You were great.
I kind of felt like Gregory Johnson. I was like, oh, I'm so glad somebody else doesn't feel comfortable speaking.
You were wonderful.